Well, again, thank you for the opportunity to come back and touch base with you. We always are talking about proposals and what we can get off the ground with all of the many opportunities you have here at Methodist to get research off the ground. But it's one thing to think about, it's another thing to, move forward. I know one of our objectives is coming here through the Research Council with the educational sessions. And we'll be talking a bit more. I know some of our educational sessions next year will be talking about like the difference between, again, QI, evidence-based practice, and research, but talking about how they can kind of blend and fall over into another category depending on what you're trying to address. I'm going to touch base today just real briefly on some real pragmatic things, ways to think about great ideas for clinical practice that can benefit from research, and touch base on some things that we had talked about in one team in terms of a potential grant proposal. I think the thing that we always have to remember about the grant proposal is when you think about who's reviewing your proposal, they're not only looking for like an overview of what you want to study, but they want to see a plan. They want to see how are you going to execute it. And so it's really a blend of those two things when you actually write a grant proposal. And I'm not going to go into all of the details. I know you have up on your CE website a handout with the slide deck as well. And we're recording this today for the benefit of those folks who couldn't join us. But I think that's one of the things that we want to emphasize today is how is that different in terms of when you just think about like writing a manuscript as opposed to writing things out to then as a grant proposal. If you're thinking even about a manuscript, I know I addressed this group on writing manuscripts and things like that. The sections of your proposal aren't all that different than the manuscript, because the manuscript usually is something that is produced after you've done your study, so you're writing all about what you did. And in today's age of publication, you'll also see a lot of journals that are dedicated just to the projected proposal. They want to get their research topic out there, their design, and what they're planning to do. So it's kind of a mixed bag when you actually go to journals, sometimes whether you're reading a study that has been done or you're reading about a study that's being proposed to be done. It doesn't matter what, those sections are the same in your grant proposal, just like you would be putting together if you were reporting in a manuscript on your research findings. You know, the thing about what I always get excited about is a great grant proposal starts with a great idea, right? We want to find the gaps in the research, and again, as I look around the room, and all of us have a nursing background, you know, oftentimes I migrate right away to, what's the nursing intervention? What's the nurse-led nursing intervention? Not to say that we don't work within the context of a multidisciplinary team, but sometimes the nursing perspective can be part of a multidisciplinary study. For example, we're working on a research proposal right now. It happens to be with the Med Center, but it could be here too. But we have an epidemiologist involved from the public health department. We have a group of doctoral students, actually they're DMP students working on the nursing part. And then we have another piece of that where it's actually working with the nursing staff. And what they're looking at, and oncology nurses, any oncology nurses here with me? Okay. Well, you probably know oncology nurses, and all of us at some point were exposed to hazardous drugs. And particularly in the oncology field, given that they are administering toxic drugs on a routine basis and all of that type of thing, they're at risk for high exposure to hazardous drug exposure. The Oncology Nursing Society has a really great evidence-based toolkit that is out there that speaks to all of the things that we should be doing to reduce our exposure to hazardous drugs and how to manage drug handling. Well, sometimes even though that may be in place in policy and procedure, it doesn't always get operationalized to how we consistently manage it. And so the nurse-led piece of that will be not only to update the policy and procedure for that based on these guidelines that are out from the Oncology Society. The epidemiologist is coming in to do white studies pre all of this, and then we're following up with new research that is out and really is on the cutting edge about how audits will sustain your practices. And there's new work being done nationally on how auditing the work site in terms of use of personal protective equipment or PPE is helpful. So I'm just saying, you know, the nursing-led component doesn't have to be limited to just nursing. You can have the multidisciplinary team with you. But the piece is to find the gaps in the research. What are we missing in practice? Again, this is just a quick slide to remind us that when there is a need for change in nurse practice, does it warrant further exploration? Does it warrant a research study? An exemplar is, this one happens to be, a few of you here in the room, we had worked a little bit on this potential opportunity that might come forward if we look at non-ventilator acquired pneumonia and what the opportunities were to reduce hospital-acquired pneumonia for that population, for non-ventilator patients. There was a speaker here at the spring Methodist Research Conference from Sparrow Health System who talked about the research and evidence-based practices. So that seems like maybe an opportunity. We've known for a long time about the ventilator-associated pneumonia in critical care, and that work has been implemented really solidly in most institutions, including here at Methodist. So just from an exemplar, where do you start if you think you potentially have an idea? You know, okay, so aspiration is a common etiology of non-ventilator associated pneumonia. We know that these are the underlying mechanisms. The oral cavity becomes our biggest concern. And the reality is that no matter who the patients are, hospitalized patients have this increase in biofilms, they have a decrease in immunity, they have a decrease in commensal bacteria, and then they have an alteration in their oral pharyngeal airway often. They've been intubated. Did you know that up to 48 hours after a patient's been extubated, they're still at risk for some weakness of their oral pharyngeal airway? For example, I'm just, you know, pointing out the evidence out there. So anyway, so that is an opportunity to think about, well, is there an opportunity to look closely at that within an organization to say, is there something more that can be done with, you know, protocols that address that? There's a grant opportunity that I don't think we've talked about a lot here at Methodist, but we were looking for grant opportunities, and the Academy of Medical Surgical Nurses has a grant opportunity up to $10,000, and, you know, they are looking for initiatives or grant research that is conducted, you know, in the medical surgical area. So we always want to think about where would be a good fit for a grant. Obviously, potentially, this grant could be with the ONS Society, but I don't know, for those of you who know a lot about oncology nursing, there's been an abundance of work done around oral assessment for the immunocompromised patients, you know, with cancer and things like that, and there are a lot of protocols out there for oral care already being implemented. So, in this particular society, who is granting a grant of $10,000, if you look at it, what are they expecting? They want the same thing that you might put together to write a manuscript. The thing that is different is that they also want a timeline, they want letters of support, they want, you know, biographical sketches, and really that's just a type of, what do I want to say, a CV or, you know, just your work history and how that supports that you have that expertise to be part of that research team. So when we think about the key sections of the proposal, when we would be, you know, putting together a proposal that might go off to the Med-Surg Association, you know, they want an abstract. They identify that they want a clear statement of the problem. You know, that's not too hard to understand. They want to know what, if you identify that you want to reduce the risk for patients to not acquire hospital-acquired pneumonia, double negative, sorry, to not be at risk for acquiring hospital-acquired pneumonia for the non-ventilated population. They want to know what would that problem statement be, and then briefly, then what is the gap of research? What's your problem to be solved? You want to identify what would you do about that problem. Again, when we're writing a proposal for a grant, they want that single statement. And I put some like key terms in here. Like if you were writing a problem statement, these are really like examples of how you could like frame that kind of keywords to start your problem statement. You want to overcome difficulty with, you want to discover what, you want to refine the current understanding, you want to find a new interpretation, you want to understand what makes something successful or unsuccessful, or you want to implement X, Y, or Z to address the key issue with the patients that are at risk for non-ventilator hospital-acquired pneumonia. So perhaps a grant proposal might address something like this. The overall purpose might be something like, you know, what is the impact of an oral care protocol for the hospitalized patients at risk for non-ventilator hospital-acquired pneumonia? I think one thing that was really interesting as a group considered that we worked with over the last couple of months, like what might be the issue. I think one of the things that was really demonstrated by some of the group work that was done by the team that was looking at this as a potential area of research was, how do you operationalize some of it? In other words, we already here at Methodist have a very clear protocol for patients in the critical care who are ventilated and oral care and that type of thing. For the patients who are on the head and neck unit, there are really, you know, that's really obviously a high-risk population, and they have a protocol. So are there other patients that are hospitalized that could be identifiable as a cohort that you would target for the research intervention? So I think that was one of the things that, while it may seem really simple right off the bat to say, oh gosh, you know, here at Methodist we could look at an oral care protocol for the non-critical care patients who are hospitalized but may be at risk for non-ventilator hospital-acquired pneumonia. But how do you identify that? Do you put something across all units and use those kinds of resources for protocols and oral care kits? Is that warranted? So I think a lot of work went into the team looking at, you know, who might the target populations be here at Methodist? Where are your high-risk patients located that are particularly at risk for this? Because overall, the non-ventilator hospital-acquired pneumonias at Methodist have been very minimal and very stable over time. So that's really the question of, like, if that's our only target outcome and that's been stable, you know, does that warrant you doing something even from a research perspective across the population? So I think that's why when you look back at that original purpose statement, you see that it was targeting, you know, the high-risk patients. But the aims then, the granting organization wants to know, what are the specifics of the grant? What are you trying to target that will help you meet your goal of getting that purpose addressed? Remember that an aim is, I always liken it to kind of a goal to get to the purpose. Remember, aims can be related, but they don't have to be dependent on each other. So aims can be laid out very sequentially. They can address different aspects of a research study. And there are different ways to look at that. Here's just some exemplar aims that might fit with what a team might want to look at if they were to identify a high-risk group of patients outside of the critical care setting, outside of what they already have identified as a high-risk unit like the head and neck unit. What then would an oral care protocol do for these particular aims? Could you reduce or improve the outcomes of patients? There's always that piece that in order to be effective with a research protocol like an oral care protocol, you would have to look at what is the comparison between your usual way that you produce, thanks, appreciate that, Karen, the way in which you normally carry out oral care and what is being proposed to be your protocol. I think one of the biggest other aims, that number 2 there, is looking at the feasibility and the potential utility of that for hospitalized patients. And a big factor that we're not like laying out today is how do you identify those other hospitalized patients who are at high risk? How many of you, like if you think about your unit or your care setting that you give care in, who might be the patients really at high risk that you would say, gosh, we should have a focus on oral care for them, outside of the units we've talked about? Who are those patients? Older adults, definitely. We know that physically as people age and there's weakness and that type of thing, they're at risk for that. They're more at risk for, swallowing impairments, that type of thing. Good. Any other populations?
NPO for a long period of time.
NPO for a long period of time, absolutely. Yeah. All of those things can put that at risk. So what's really key is to identify the right target population for this type of study if this were to go forward. And the other thing is to compare the clinical effectiveness of that oral care protocol to standard oral care. And clinical effectiveness does not have to only mean looking at hospital-acquired pneumonia rates. It can also be looking at the other the other effects of that in terms of, the oral care, just the comfort piece of it, the actual oral assessment can demonstrate some of that for clinical effectiveness. I mean, those are just a few exemplars. So we haven't really delineated out all of the ways in which we would measure that, but that's a start on it. I think the biggest challenge with implementing a research study like this is to really be able to well delineate who needs a more intense protocol outside of the critical care setting or in obvious units like a head and neck unit where all patients, kind of meet that criteria. So I think that's a real challenge for a study like this. One of the things that helps really get at the heart of the proposal is the literature review, and all of us have read articles. We know that a literature review really summarizes what's the state of the science. And at the beginning here, we gave a few examples of why, this is such an important topic for nursing care for the patient. And that isn't to say that we aren't doing oral care for patients who are hospitalized. We just wonder if there's additional things that we can do. So a background of the topic and then the synthesis of the available research to identify potential gaps. And I think that's sometimes where there's a yin and a yang to identify, is there enough of a gap in what we see in our current practice to warrant additional research. So I think it's really important. And when teams do that, your research teams here at Nebraska Methodist Hospital, that you start to see, what are some important research priorities for us. There are a lot of things like when we pull together a grant proposal, most grant proposals want you to make sure everything hooks together. Make sure that when you talk about the linkage between the problem that you've identified, what your concepts are that you want to examine or measure, that all fits together. It doesn't necessarily mean that you have to have some grandiose framework. We all work here at the Methodist Hospital. You work with the Iowa model. It is a type of dissemination and implementation model. So it's a great model to even frame, your research study. It helps give you direction for the components of your study. So you don't have to be grandiose about things. You don't have to, use grandiose theories. I mean, if it fits, that's good. Meaning, if you were going to be measuring something around the perceptions of nurses, well, this would be more applicable to the patient, excuse me. If you were going to use social cognitive theory, you could use it with nurses too, but if you were going to use social cognitive theory and think about self-efficacy, that means your confidence in doing something. Oftentimes, we use that concept or theory of self-efficacy when we think there's something challenging to overcome. In the case of doing oral care for a patient, I would venture to guess that most nurses would be very confident of their ability to help carry out oral care for a patient. They knew what the protocol was. So there might not be any purpose in looking at self-efficacy, for example, in a study where we were doing oral care. If it were more challenging, for example, for the patient, let's take an oncology patient, where there's ongoing work that has to be done, not work, but ongoing treatment that has to be done, and so you're very concerned about their oral mucosal breakdown and that type of thing, and a potential source of infection, you would want the patient to have a high level of confidence or a high level of self-efficacy that they could carry that out. So I just wanted to point out that your framework doesn't have to be a lot of theory. It can be something very practical, very pragmatic, much like the Iowa model. There are several models like the Iowa model out there that are dissemination and implementation models that kind of guide us through the steps of research. I just had another slide here to just kind of briefly give another example. A model like the Iowa model really is much more specific than a theory, and it can be usually shown in a diagram or picture. And grant proposals especially benefit from having you to be able to picture for the grant reviewer what you want to do. And when you have a model like the Iowa model, it can lend itself real easily to a graphic display. So I always encourage you, if you're going to work with a grant, a model is very helpful. I wanted to just share with you that there is actually a website, because a lot of the research that nurses do, particularly when we talk about nurse-led interventions and that type of thing, are really dissemination and implementation types of research that the models can fall under. There is a website out there just called www.dissemination, implementation.org that you can go to, and there is a listing of all of these models, and they have a hot link with each of the models. And you'll find the Iowa model on there. You'll find a lot of the models. So I always encourage you to think about that if you're thinking, gosh, you know, I would like to depict for a grant reviewer how we're going to approach this. And a lot of times, these types of models can be really helpful for you. But again, your organization has already adopted the Iowa model, and I would encourage you to just continue to use that. It's a great exemplar of a dissemination and implementation model. Another exemplar is the REAIM model. And the REAIM model adds kind of another component that is often called out about the reach, how you reach the participants that you're targeting, and the participants can be both the nursing staff and the patients. For example, if we were going to do an oral care protocol. And the other thing that the REAIM does is it really wants you to enact and identify how you're going to track or determine if something has been adopted. And that would refer to, in a case like with an oral care protocol, how has that been adopted by nursing units? So sometimes different models call out different aspects that are important to a given type of protocol you want to implement. And so it's fun to look through that listing of the dissemination and implementation models for you to get some other ideas. When we actually write the methods section of the grant, it doesn't have to be lengthy. The methods literally depict what you're going to do. So it's going to include what is your sample, who are you going to target to participate. In some cases, it's both patients and nurses or other interdisciplinary team members. You also need to identify how you're going to sample. Is it all of the patients on the unit? Is it a select group of patients on the unit, or patients who have certain criteria? So that's where the inclusion-exclusion criteria come. Often with these dissemination and implementation studies, you often include all of the patients on a given type of unit, for example. So don't be shy about identifying if all patients should receive a certain, like, nursing-led intervention. That's kind of the beauty about nursing research, is that oftentimes we target specific nursing units, or we are comparing a couple of nursing units to other nursing units to see how the uptake was of that nurse-led intervention. So there are different ways to identify who your sample are. So it doesn't have to be robust. It just has to literally tell the grant people they're not there to, like, criticize or critique your grant. They're there to look for clarity. It is much different, especially when you're looking for funding, not the $1 million funding, but when you're looking for funding to look at grants that have kind of a specific target that they want to hit. And for example, when you read the purpose and direction that the Academy of Medical Surgical Nurses wants, for example, they want to target improvements in the hospitalized med-surg patient. So you don't have to be, like, get crazy about what you write. You need to describe your data collection instruments. And we always start by using, what are we going to use for measurement? Are there standard tools out there? What has been reported in the literature? What have other people used when they've implemented or used, like, for example, an oral care protocol? And a lot of that type of thing, we can learn a lot from what specifically colleagues, our nursing colleagues, have done in critical care units, when the early work was done about how do we measure, how do we look at the use of oral care protocols, particularly for the ventilator patient. We also want to talk then about how will the data be processed? What data are you going to collect? You've identified your data collection tools, but what data processing will we use? Are you going to use descriptive statistics? Are you going to use inferential statistics? Are you going to use predictive statistics? That is all driven by your questions and what you delineate about what data you're collecting. So it all starts all together. So the big piece again for grants and grant funding is the timeline. They will be looking particularly, given what is the scope and how big is it of what you want to study, and whether that timeline seems feasible. Does the timeline seem feasible to implement that within the scope of what they want? And a lot of our smaller grants, they usually want to see results like within a year. So they're looking for a timetable that doesn't exceed a year. I know that sounds real simple, but, you know, as a grant reviewer, sometimes you're looking at this and they give you a timetable that says 2 years. Well, I respect and understand that it can take a long time to do it, but that funding agency wants results in a year so they can keep, you know, moving forward and seeing the benefits that you've demonstrated through your grant work, and they can continue to fund other studies. So timetables are important. And then the other thing I always share with people, and maybe we've talked about this before either in Research Council or at our meetings, but budget. If you're going to do a research study and you want to apply for a grant, you have to have something that you need money for. And a lot of times nursing studies need help with the data collection. They need help with the statistical analysis and, you know, support like that, data entry, that type of thing. So we don't need to be shy about it. Sometimes we might be asking for software or devices that can help collect data. That's very legitimate, and but we need to make sure then that we've woven all of that back into making sure. If you say you need somebody to help you data collect and all you're going to do is pass out a survey to nurses, they'll say, what do you mean you need 3 $3,000 to have somebody help you data collect. It's like, really? You know, so there has to be congruence with all of that. But I always say to people, like, if you can do a research study without a budget, or you can do it on a shoestring budget, then you don't need to apply for a grant. But I can't believe that there aren't things that you need. Sometimes it's bringing in experts to help do a core training on something. You know, you need budget for that. You can put in budgets depending on the grant restrictions. You can put in money for travel for people to present. So there are different grant restrictions when they have the budget. So it's important to look at that and think about that and what's really doable and what do you need to get it done. You know, what do you need to get that done? I think that's really always the big question that people want to know. What would I use it for? Design. People would say, oh gosh, you know, what do they mean by design? Well, the overall purpose of your study is to answer a given research question. We have to find what design is going to be the most rigorous for answering that question. And so sometimes if you have a higher intensity dose of an intervention versus a less intense dose, it can be helpful because now you're parsing out and trying to decide how intense, for example, does an oral care protocol need to be. You know, that's an example of putting some rigor to the research to determine what is the dosage that's needed for a given nursing intervention. And so your design will be driven by what do you want to find out, what do you want to study. And then if you start really thinking, what hasn't been answered in the research? I think there's a lot of stuff that hasn't been answered about oral care in the hospitalized patients. I think the challenge is who needs it. We know all of our patients get oral care, but do some of them need different intensities of that oral care? Or they can't do it themselves, so we need to make sure we're doing this system on that. And then the research design really then allows you as a researcher to implement your plan and practice. If you're going to say, well, I'm going to compare a high intensity versus a low intensity dose of an oral care intervention, you'll have identified what those protocols look like. You'll have identified what your populations are. So it really helps to lay out the plan, and the research design that you have laid out then will be looked at by the grant reviewer to see if they understand that there's enough difference between the two protocols that you can actually answer the question, how does the dosing of an oral care protocol impact outcomes? So the research design, it doesn't have to be fancy to be a research study. It doesn't have to be, you know, a confusing research design. There are many things that can be used as you design. You know, before and after comparisons, you can do a run-in period for normal care, and then add your intervention. You can do one unit with a run-in period where normal care is being given, while on another unit you actually are carrying out the intervention. You can do the same thing with a low intensity versus a high intensity intervention. Like you start out using the low intensity intervention, you measure the impact on that unit with that population. Then you ramp up and you do a high intensity intervention and look at in that population what the outcomes are. So design can help you answer questions that have not been explored in the literature or the research today. And then finally, I wanted to share just a little bit on research design. This also came from, I gave you this reference, even though it's an older reference, like from 2005, it just so succinctly gave you this great table. And it will be up on your website, on the CE website. But it talks about the experimental design, the quasi-experimental, the descriptive, the comparative, the correlational, the epidemiological design. It just was like crisp. And it doesn't have to be fancy, and you can work with that to think about what you want to do with your research study. What is the question to be answered, and what study design helps you answer that question? So you always want to look for the linkage. Here's my question. Here's how I want to study it. That's my research design. Your question doesn't always imply what your design is. And this is just the second page of that same table. It talks more about quantitative designs, retrospective and prospective. So from an exemplar standpoint, there are several things that the evidence in the literature would suggest. Certainly, some type of protocol, worksheet, nurse surveys, real-time surveys about oral care, patient real-time surveys about how implementation is going. Much of the literature, a lot of us are pretty familiar with different types of oral assessment tools. A lot of the literature continues to reference the Beck oral assessment tool as a good way to just see, how effective is oral care being done on particularly high-risk patients. Not to be critical of the nursing care, but to just see when you go to look at somebody's oral cavity, does it kind of meet the expectation that they've had adequate oral care recently. And then, of course, the really big outcome is the incidence of hospital-acquired pneumonias, but we know that because you have such a low incidence, it's hard to capture any big shift in that. And then certainly reach. How many high-risk patients were you able to reach through study? And again, based on what criteria did you do that? What about length of stay? And again, that's kind of like that incidence of hospital-acquired pneumonia. I'm not sure that you would expect LOS to change much unless the patient has some type of complication. There are certainly nursing knowledge and perception tools out there about oral care. The reach can also be looked at by the oral care supply use on units, and certainly the feasibility measures, where you would really want to know from an implementation standpoint. And again, if you were comparing like a low-dose, high-dose implementation of an oral care protocol, how is it used? Is it easy to use? Can it be integrated? Does it just stress nursing staff out to use it or think about that? And again, I think we can learn a lot from critical care and, for example, some of the units that have really high-risk patients about how they implement or integrate that. So those are just some examples of like if you were maybe to start thinking about oral care protocol, if it was a high priority, if you saw that as a high priority, where you might start with a research design. But again, there are other ways to look at it. Again, the dose of an intervention can be really exciting to look at, because I think a lot of us would agree that some patients, because they are able to some degree participate in their care, they may need just a low-dose intervention of like, trying to put that patient on that regimen versus a nurse helping with that. So budget. So if we were thinking about this type of study, materials, what other things do you need? You need to collect data. You may need to, if you decided, I don't know, maybe you want to put a tongue scraper in your oral kits, but that's not part of your oral kit now. Maybe for the study you'd want to have enough tongue cleaning devices that you could use. Personnel, you might need help with enrolling subjects and making sure everything gets rolling on units who are going to participate, data collection, data analysis. There certainly could be some opportunity to use some kind of app device or something around that. Consultation, travel expenses. I was thinking a little bit in terms of reviewing the literature, even like oral assessment, looking at the oral cavity, having the app where you have the Beck tool there and that type of thing. So there are some studies out there that have done some digital work around that. So that is an example, like in this particular budget for the Med-Surg Association, these are some examples of things that, they would allow in their study. So a grant proposal, it doesn't have to be hard. It can be, it's really part of that work of finding the great research idea where there's a gap in the evidence that deserves more of a research study. Or maybe the gap in the evidence is such that you can fill that gap in some other way, maybe through a change in practice, through policy and procedure and other types of things. Maybe you have enough of the evidence that is already being implemented in your institution that you don't need a research project. But I use that example of the oral care just to give you kind of a more concrete way to think about that. So I think we have a little time for some questions. If you have anything you'd like to bring up or to share about research or ideas you have for research on your units or in your area. Thank you. Thoughts from anybody on grant writing? It doesn't have to be hard. I am amazed that a lot of times the grant, for the smaller grants I'm saying, and those are the kind of grants we want to go after. Those are the ones that can be the just in time. They can get that money out to us quickly. Now that doesn't mean that we can't consider for Methodist a much larger grant, grants that are, much more robust. But that might be then like a hospital-wide initiative where we do some feasibility testing first and that type of thing where we look at much larger grants. But a lot of times, the nurse-led intervention grants or the types of evidence that we want to put into practice can benefit from having some additional help to carry out the grant work. And it really provides the framework for you publishing the findings because you've done all the work to frame it all. Now you just have to put your findings together. And I make that sound real simple, but it's a process. And I think we're all here. You have such a great research council. You've got a great practice council. And so if there are any types of things that can be moved forward, I would encourage you, even if you're not sure that sometimes you want to go forward with a full-blown research proposal. Sometimes these small grants will fund feasibility, usability studies. And that's where you get enough of a taste of whether in your institution a research next step is needed. And so I don't want you to be discouraged by thinking, oh, I've got to have this idea, I've got to, make sure I have all of this framed and everything. Sometimes it can really come from the grassroots where you want to explore something more and you have a great idea for a piece of an intervention that you want to test out. So I just want to encourage you that we have opportunities that we just haven't turned over all of the rocks. And even like the Critical Care Association has a $50,000 grant every year, and it's a great way. I mean, I was looking just the other day at what got funded, and a lot of the things that are getting funded are really at that level of where they're looking to see how this new innovation might work in the critical care area. So it doesn't have to be fancy. And I call that critical care. A lot of that's my background, but my point being is I see Lola here and Karen here today too. And I'm just saying $50,000 can get you a lot of data collection. It can help you get travel and things like that to promote the work that you're doing. So we just have to find it. Jen.
So I've never submitted a grant.
Yeah.
This is a cool question, but when you submit it, is it either you receive it or you don't, or do they ever respond back and say we suggest these revisions, like a manuscript, or how does that work?
The organization, it depends on the organization. I have never reviewed for the American or for the Association of Med-Surg Nurses. I reviewed for ANF grants, I've reviewed for AACN grants and ENA grants, and most of the organizations now will usually give you the feedback from the reviewers. Because they did not used to do that. They would just say it wasn't accepted. It is now really being pushed that the summarization of the grant review is sent back to you. That you can make some determination. You may still be able to carry it out. You may be able to reapply, find another small funding agency to fund you. So that's a great question because I think that's important for any of us. In fact, Jen, you and I were talking this morning about abstract reviewing. And even oral and poster abstracts, the associations that I review for, there's places for us to give specific comments on the abstracts and posters. You will get a notice back, like if your abstracts have been accepted for poster or oral presentation, but you usually also now get at least some feedback as well. Yeah, so that's good because in the past, like 10 years ago, it was not very common for reviewer comments to come back to you. You didn't really know why you didn't get funded. Right. And I think we learned, I think, Jane, you were at that conference too when the college, the Methodist College had that grant workshop, that there are a lot of private funders out there that if you have an idea, we just have to try to scurry around and try to find other organizations that might find it fun a great idea. So I would encourage us to keep moving forward. I would encourage us to think about the feasibility and usability kinds of things that we could push forward into small grants, because that way you have a chance to test something before you go full bore and try to implement something house-wide or on several units or whatever the case may be. Because there's a lot of work you have to do just to get things standardized and framed even for a feasibility study. So I just encourage you to think about that. Other questions or comments? Okay. Thanks, Carrie, for the invitation, and thanks everybody for coming today. Have a great afternoon.